my name is Dr. Tycel Phillips. I'm from the City of Hope National Medical Center, and I'm here today with an esteemed panel group discussing some of the evolving topics in CLL. I'll let each panelist introduce themselves.
Hi, I'm Dr. Seema Bhat from The Ohio State University with expertise in CLL.
Hello, I'm Erin Mulvey from Weill Cornell Medicine in New York City.
Hi, I'm Danielle Brander. I'm at the Blood Cancers Institute in Durham, North Carolina.
Hi, and I'm Andres Chang. I'm from the Winship Cancer Institute at Emory University.
All right, guys, thanks for joining me. We have a very exciting discussion today. So to kick things off, just to put things in perspective for our audience, CLL is probably one of the most fundamentally studied sort of heme malignancies we have. So what are some of the key genomic aspects we're looking for in patients when they come into our clinics? Dr. Chang, let's start with you.
Sure, yeah. So I think that over the years, we have learned a lot about CLL and how certain aspects of their genomic and their genomic composition have shapes outcomes and shapes treatment responses. And just to summarize from a clinical standpoint, I think that the most important aspects that we need to consider right now is whether their baseline immunoglobulin heavy chain has been mutated or not, and also if they have some chromosomal abnormalities, particularly the one affecting the chromosome 17, where the gene TP53 is housed, as well as whether that gene specifically has been mutated.
So Dr. Brander, how are you using these tests in your day-to-day clinical practice? And when you talk to patients, how are you explaining this?
Yeah, so for a new patient, I think these markers are still very important, despite the therapeutic advances where fortunately even patients with the highest risk TP53 aberrations are doing well on novel treatments. But as you point out, they're still very important to know those markers around the time of diagnosis, particularly for patients where you want to tell them a little more of what to expect. Of course, about a quarter of patients with CLL never require therapy. They're the highest risk patients, but then there's lots of patients in the middle. So I'll integrate the markers into, say, the CLL IPI score, which uses various things in addition to the genomic markers like the beta-2 and their clinical stage. And while not perfect, it helps give an expectation of the likelihood of needing treatment. But again, even with the novel therapies, as we're hearing at the meetings, mutated versus unmutated, now with more time-limited therapy, I think there's lots of ways also for treatment, and it's helpful to know that information ahead of time.
Yeah. And Dr. Mulvey, if you have a patient and you get a baseline set of markers, and say they go an extended period of time without treatment, are you rechecking these markers to see if there's been any evolutionary change in the clones, or are you just going based on what you've done before?
That's a great question. I like to always at baseline assess very thoroughly genomic markers, et cetera. And in patients who are able to be on watch and wait and observed over time, I generally don't repeat all of those markers unless there's a substantial amount of time that's passed or there have been updates in the assays that we're using. I'm typically repeating those tests for patients who are on treatment and progressing, or if there's a different treatment decision that I'm making.
Okay, good. So Dr. Bhat, before we start discussing the individual drugs themselves, I think the whole theme of this is that these prognostic markers and baseline genomic testing sort of hopefully lead us to make sort of decisions for our patients. Do you think that's something that fundamentally every patient with CLL should have done? Or again, in certain settings, I'm sure that testing isn't as easy in certain areas. Do you think this is something that every doctor should do? Or again, you do it when you can, and other times you can sort of just bypass it?
So that's a very good question, very relevant question, because not all patients can be seen in academic centers. Patients are seen in the community, patients are seen in the rural centers where we may not have all the resources available. So there are a lot of limitations in how we can practice. However, if a patient is nearing treatment, there are certain decisions that we make based on these markers. So it's very critical to have this information for, number one, to determine what treatment to choose for them. Because we know historically for patients who have the chromosome 17 abnormality, they don't do well with chemoimmunotherapy. There is evolving data that some of the targeted agents may be better for those patients. Similarly, the IGHV mutation status can determine response as well as prognosis. That means how a particular treatment is going to work and how long a particular treatment is expected to work. So to tailor treatment, choose treatment based on these genomic markers, it's very critical to know this information. It helps us choose the right treatment for the given patient, kind of moving towards what I believe is personalized treatment for CLL.
So, Dr. Brander, just to piggyback off of that, I think one of the fundamental changes that have happened in the last decade or so has been the introduction of these BTK inhibitors. We've went from one to now we have multiple. So how do you sort of look at the class itself, and with so many options, how do you choose what's best for your patients?
Yeah, very great question, one of which can take a long time, of course, I'm sure everyone here knows, to counsel patients on. And as you pointed out or asked the question about was more directed at BTK inhibitors, of course, from a fixed duration perspective, we now also have the whole category of fixed duration, either venetoclax with obinutuzumab or maybe even combined with the BTK. But for a patient where for one reason or another, you're leaning more towards the BTK monotherapy or BTK plus obinutuzumab, and I think most of us will lean towards the second generation covalent BTK, either acalabrutinib or zanubrutinib. We all want to be evidence-based in how we make a decision between choosing between those two, but they haven't, of course, been compared head-to-head, and overall, I think they're fairly similar from what we see in the relapsed refractory and appear to have less toxicity, of course, than ibrutinib, which is why we go to them. Sometimes I make a decision between acal and zanubrutinib over logistics, because zanubrutinib has data looking at once a day versus twice a day for patients concerned about compliance. Sometimes from an approval perspective, if I know I want to do obinutuzumab, anti-CD20, either for autoimmune reasons or faster, deeper response with the BTK, then because of the approval with Acala, I might lean that way. Various people probably factor in headache profile differences or hypertension maybe. But I think for those going the BTK as the primary monotherapy, the second generation are there. We're not yet, of course, frontline outside of trials looking at non-covalent BTK, but I think this conversation might get more complicated in a good way in the next couple of years.
Yeah, very good points. Dr. Mulvey, are there any patients you think that may not be good candidates for a BTK inhibitor?
So I think BTK inhibitors have absolutely, as you mentioned, revolutionized the treatment of patients with CLL, and different strategies can still be used using BTK inhibitors to treat the majority of our patients. I think what we're beginning to learn is that there are certain patients who benefit from combination therapy a bit more, and some of the increase in toxicities that we see is warranted because you can overcome some high-risk features. Things like TP53 mutations, things like Notch1 mutations, et cetera, where I think previously I had used a lot of continuous BTK therapy. I think there is increasing evidence that combining BCL2 inhibitors with BTK inhibitors can be a very useful strategy. And the duration of treatment is one that I think is yet to be determined, but likely a year seems to be potentially insufficient.
Yeah. And so, Dr. Chang, as we've used the BTK inhibitors, and thankfully for CLL, it's demonstrated very long remissions in patients. We've started to see some different mechanisms of resistance come up. How would you counsel, say, another provider who doesn't necessarily specialize in CLL about, when to check, what to do with it, and should they sort of make any changes based on their finding, given that, you do, in this situation, at least now in the United States, have options?
As we increase the usage of BTK inhibitors, particularly the covalent BTK inhibitors, we are seeing an increasing number of individuals who are becoming resistant to it. And I think that over time, as we learn more and more about these individuals, there are particular mutations both within BTK, particularly in the cysteine 481 residue, where these covalent BTK inhibitors bind, that we see that these mutations are coming up, and that's providing the mechanism that explains that resistance. But there are also other mechanisms, and oftentimes when we do the testing, we don't necessarily detect a known mechanism. And so that just highlights the need for further research to try to understand more what is happening at the biological level. From a practical perspective, I think that if you're in the community, I don't necessarily think that you need to go down into getting all this testing, because the patients are going to know, right? And you will, and the provider is going to know just based on blood counts and based on the presence of symptoms and so forth. And so at that time, I think that what is really important to know is that you shouldn't go from one covalent BTK inhibitor to another covalent BTK inhibitor, because they all use a similar mechanism. And so the chances are that if you do something, an approach like that, that second BTK inhibitor is also not going to work. And that's when we need to think about other alternative treatment approaches, like the use of BCL2 inhibitors or the use of non-covalent BTK inhibitors.
Yeah. So it's a very good segue, because you brought up the non-covalent BTK inhibitors. So our third generation BTK inhibitors, I think what we've seen from first to second, and it even appears that way with third, is that we've all seen some benefit in maybe a toxicity profile. But given what we know about non-covalent BTK inhibitors and the covalent drugs, Dr. Bhat, how would you sequence these things? Because now there are frontline studies looking at pirtobrutinib and the other non-covalent drugs in the frontline setting. I mean, what do we know and what do we don't know? And can we go covalent to non-covalent, non-covalent to covalent, or is it just mix and match here at this point?
So this is a very important question and a very relevant question at this time, given that we are talking around ASH 2025, and a day before ASH started, we got the full FDA approval for pirtobrutinib, which is a non-covalent BTK inhibitor, and it was approved in the second line setting after patients had progressed on a covalent BTK inhibitor based on the trial that was presented last year, Bruin CLL 321, where pirtobrutinib was compared to investigator's choice. So based on that data, that approval, and the upcoming data that we see, I do think, and given that if a patient who is on a covalent BTK inhibitor progresses and has the BTK mutations, given the sequencing, I don't see any downside in going to a non-covalent BTK inhibitor, pirtobrutinib, before switching classes. It's, as you said, it works very well. And it's very safe. The toxicity profile it's a very clean drug. With BTK inhibitors, we worry about cardiac toxicity, we worry about bleeding, we worry about some other side effects, but these are the major things. In trials, we have seen that with the cardiac toxicity or the effect on the heart, the major problem is irregular heart rhythm, which is called atrial fibrillation. The rates were very low compared, and now we have a head-to-head comparison, which was presented yesterday at ASH between ibrutinib and pirtobrutinib, where we had much lesser atrial fibrillation rates. Given the safety and given progression on a covalent BTK inhibitor, I think it's fair to stay within the class, to go to pirtobrutinib at that point.
Okay, no, that's great.
The second part of that, right, is like you mentioned, do we have data going from non-covalent to covalent? I think that is an unanswered question right now. And so I will be very cautious about that. I think that the trials, as we move along and as we get more data, is going to provide information about that. But as of right now, from a routine practice, I would probably not recommend that.
Right. I'm also very enthusiastic about the new approval of pirtobrutinib in the second line. I think that will give access to a lot of patients to a very easy to use therapy with a very favorable tolerability profile, and we'll be able to spare patients who otherwise would have had to be treated with a BCL2 inhibitor undergoing a rapid ramp up or standard ramp up and laboratory monitoring. I agree. My enthusiasm about frontline pirtobrutinib is a little bit curtailed about concerns about kinase dead mutations that may develop. However, I think we need a lot more research to really understand. The efficacy is exciting, the tolerability is exciting, but certainly it does give you a bit of a concern about the potential sequencing of these agents.
I would say, though, that the data, the frontline data looks compelling against bendamustine Rituxan in the frontline setting, where obviously the patients didn't have high-risk feature TP53 or deletion 17p, but you did see an early survival advantage despite a crossover. So the data looks compelling, although it's not approved in that setting at this point.